Next, I will call upon Giampaolo. He is the consultant from Italy. He is going to tell us about Rezum. Rezum is the energy source which is almost like for UroLift, and the patient population is almost the same. And let's hear from him.
Good morning, everyone. And so we're going to share the screen. So we talk about the Rezum, the world's costliest kettle. So during the last 10 years, the number of TURPs performed, as you can see in this paper, have shown a steady decline from 81% of all surgery for benign prostatic hyperplasia in the USA in 1999 to only 39% by 2005. On the other hand, all minimally invasive surgical treatment, the so-called MISTs, and total surgery for BPH have constantly increased. Among MISTs, in 2015 and introduced in Europe in 2018, at present, we have one RCT versus sham treatment reported in the literature with a maximum follow-up of 5 years. What is the basic principle of Rezum? The Rezum system uses radio frequency power to create thermal energy in form of water vapor, which in turn deposits the stored thermal energy when the steam phase shifts to liquid upon cell contact. Due to the convective properties of water vapor, the steam disperses rapidly and homogeneously through tissue interstices and releases this energy, affecting cell necrosis. As UroLift can be performed in an office-based setting with minimal pain management. The physical principle, so we know that 540 calories per milliliter of stored thermal energy is released during phase change from water vapor to water. We also know that more than 70 degrees, at a temperature of more than 70 degrees, cell death is immediate and irreversible. During a Rezum treatment, 103 degrees water vapor is convectively delivered into 37 degrees prostate tissue. So the temperature of tissue increases to 70 degrees over the course of 9-second treatment, resulting in instantaneous cell death. Another interesting point is that convective thermal energy is delivered homogeneously within the targeted area, as shown in the picture on your left, and does not go beyond the transition zone boundary. On the other hand, as shown in the picture on your right, the conductive heat transfer cell to cell, so a non-uniform heat gradient results in cell near source being heated substantially more than those far away. So in this case, conductive heat of prostate capsule may also occur. As reported in this paper by Dixon, the thermal energy is delivered to the McNeil's transition zone of the prostate. That is the area we want to treat. In this study, patients were scheduled for simple prostatectomy, but they were treated the week before with a Rezum system. So the extirpated adenomas, we see the pictures here, there were 7 specimens, were grossly examined, followed the whole mount sectioning and staining with TTC in order to evaluate the thermal ablation. TTC, what does TTC do? TTC stains viable tissue with healthy metabolic enzymes as a bright red color. So the bright red color of the adenoma is a viable tissue, while irreversibly damaged tissue with no metabolic enzymes does not take up stain and remains its natural tan color, the transition zone in the middle. So we can also see that the maximum lesion size reported was 2.1 per 2.8 centimeters, as shown in the 7 specimens. Another interesting point that the urethra was preserved, as shown in the H and E histologic staining. We can see a general preservation of the prostatic urethral epithelium, and moreover, there was no carbonization or heat fixation observed in the excised tissue. In the same paper, Dixon and colleagues treated other 15 patients only with Rezum treatment. In this case, as a week from the procedure, we can see an MRI prostatic gadolinium defect observed in all patients, mimicking basically what was observed using the TTC staining on adenomectomy whole mount specimens. At 6 months, the thermal lesion resolved and the transition zone volume reduced of nearly 40%, while the whole prostate volume reduced of nearly 30%. That's also shown here in the rendering image. You can see the whole prostate reduced of 30%, and the central part of the transition zone, the green color and the blue color, reduced of 40%. So this is a video of the procedure. It's a very simple procedure. It uses a cystoscope. We can say that a learning curve of 5 to 10 cases is probably enough. The more you do, of course, the better, as usual, but after 10 procedures, you're pretty confident. So with a dedicated cystoscope, we navigate into the urethra. The distance from the tip of the optic to the tip of the instrument measures 0 length from the bladder neck to the verumontanum. So we know that we have to do an injection each 1 centimeter approximately. This is not strict. It doesn't do any harm. Sorry, the video. We don't do any harm if we do more injection. Another interesting point is, as you can see, the procedure is completely bloodless, and the tissue turns suddenly pale and avascular. In case of the median lobe, 1 to 3 injections can be performed. So I can skip at the end of the video so we can see the final result. You can see here the prostate is avascular and paler than before. So this is the case, the images of the same patient. This patient has a preoperative Qmax of 6 milliliters and a PVR of 150 cc. At 2-month follow-up, the prostatic fossa is wide open and the postoperative Qmax is 21 milliliters per second and the PVR negligible. This is another case. This case was a 90 cc prostate with an IPP grade 3. And at 3 months, we can see the median lobe. This is a retrograde lesion with a cystoscope, with a flexible cystoscope. The median lobe is shrinked. The anterior part of the prostate is not treated, and you can see the adenoma is still there. And interestingly, this is the area, the verumontanum, the so-called ejaculatory cap is preserved, so is the ejaculation. So what does the literature say? In the pivotal study of McVary and colleagues, they present, this paper is ahead of print, they present in a number of April of the Journal of Urology, they present 5 years outcome of a multi-center randomized sham control trial. The demographic and patient characteristics are here reported, a total of 197 subjects with more than 50 years of age, IPSS more than 13, Qmax less than 15, prostate volume between 30 and 80 cc's, were randomized and followed for 5 years. These are the outcomes. They report a significant improvement of LUTs at 3 months post-thermal therapy that remain durable through 5 years in the treatment group. They reported a reduction of IPSS of 48%, an increase of quality of life of 45%, Qmax improved 44%, and BPH impact index decreased 48%. When the median lobe was identified and treated, IPSS and Qmax showed a significantly better improvement than in those cases when it was only identified but not treated, as shown here in this paper. These are the adverse events. In 57% of the cases, there's no adverse events, but they're typically mild to moderate and self-limiting within 3 weeks. Most common adverse events are listed here. They're dysuria, gross hematuria, hematospermia, frequency, retention, and urgency, all grade 1 according to Clavian-Dildo classification. About the long-term efficacy, the surgical retreatment rate was 4.4% at 5 years. Of those cases, 2 patients underwent TURP and 2 patients were retreated with Rezum. And at 5 years, 11.1% returned to medical treatment. About the sexual outcomes, the same in the literature. There's no device or procedure-related sexual dysfunction or sustained de novo erectile dysfunction. In our experience, on a multi-center study on 135 patients, we also observed a slight but statistically significant increase of the IAF-5 score from baseline to 6 months. A special consideration should be done to the catheterization. The catheterization time after Rezum ranges between 0 to 4 days. According to the literature, in our experience, we prudentially opted for a longer catheterization time of 7 days in order to avoid acute urinary retention. The person has a special ultra-thin self-removing catheter that allows urine to bypass around the catheter. This is called EXIM. This provides minor discomfort and especially allows complete urinary continence and spontaneous urination. It could be left in place for a month. What does Rezum may be offered to patients with small to medium-sized prostates. Patients should be counseled regarding efficacy and retreatment rates, and it should be offered to eligible patients who desire to preserve erectile and ejaculatory function. So basically, ideally, in terms of invasiveness and efficacy, Rezum locates midway between medical therapy and definitive surgery. In terms of cost, as showed in this paper by Ulkeher, the Rezum, basically in this graph, they measured the efficacy with the average IPSS at 2 years and the cost, and the best position would be down and on the right. As you can see, the Rezum treatment performs pretty well. Indeed, it outperforms most MISTs in terms of cost and efficacy, whereas when compared to TURP or green laser, shows less efficacy but minor cost at 2 years. The decision-making process, we will discuss it widely later on. At the moment, we have like a portfolio of options. We have to take into account several parameters, going from clinical conditions like medical therapy, anticoagulation, or antiplatelet therapy. And prostate volume is an important parameter to decide what type of treatment we want to go for. And also sequelae and sexual function, or if the patient can undergo general anesthesia. In this case, MIST definitely can play a role. So in conclusion, after having weighed efficacy, invasiveness, cost, skill set, we can make our decision what treatment to offer to the patient. And regarding the Rezum, we can say that is an office-based procedure that requires local anesthesia to mild sedation, has a short learning curve, 5 to 10 cases, showed a good efficacy in terms of improvement of Qmax, IPSS, quality of life, a low complication rate, generally multi-moderate and self-resolving within 3 weeks, reasonable durability, although it needs longer follow-up, and a high rate of preservation of sexual and ejaculatory function. It should be used for prostate volume less than 80 cc, but also in this case, the volume is not so strict. There are papers that report with a very short follow-up cases of larger prostate. Thank you.
Thank you, Giampaolo. That's a nice presentation. I think regarding the Rezum and UroLift, the main thing is we are waiting for like 10-year, 15-year long-term outcomes. That's the main thing. And once that box is ticked, I'm sure they are supposed to stay forever. Nice presentation. I'm very excited with your concept of using that Exim short catheter. That's a nice concept. Even though it's licensed for 30 days, I think you will be removing it in 5 to 7 days, isn't it?
Yes, yes. It's important you don't have microhematuria, because otherwise if you have clots, they can block the system. But in these minimally invasive treatments, normally the hematuria is really mild.
Yeah, thank you very much.